Hello and welcome back to my channel. My name is Dr. Jessica Katanga, and in today's video I'm going to be talking all about my job in learning disabilities. So as you may or may not know, I am locuming at the moment, which just means that I go to anywhere there's a vacancy for my agency, and for the last 7 months that happens to be at a learning disabilities facility. So in this video I'm going to be talking about what my roles and responsibilities were, a little bit about like LD in general, and then some of the challenges. There definitely was some challenges and traumatic moments, and then also my highlights. So if you are interested, stay tuned and let's get right into it. So let's start off with like the LD specialty. So I was working 12-bedded inpatient unit, and it's for people with moderate to severe learning disabilities who also have psychiatric diagnoses. So these consultants, they would be managing regular psychiatric diagnoses that require inpatient facilities. However, it is now in the learning disability population because, of course, managing a relapse in a adult of the majority population is different to an adult with learning disabilities. So that's what the patient unit was for. But unfortunately, most of the time, it actually ended up just being people who, most of the patients were in there because of something we call placement breakdown. So these adults are usually in the community, and they're either in like supported living, or they're in their own accommodation with like a care team around them, or they're with their parents with like care around them, and then for whatever reason the placement breaks down. So that's usually like challenging behavior, or maybe the placement has closed down just itself, like staff changeover in the community. Then that all might make the placement break down, and then they've come into hospital. The structure of the week would be, so I was working 4 days a week. On Mondays and Wednesdays we'd have the team meeting, so that's the MDT, where we would talk about each patient in turn, and we'd all give our like updates. And then we would also have meetings scattered throughout the week for each patient, and those meetings would be for us to discuss them, or for us to now link in with the outside, so like social care or the commissioners. So these are people who allocate money to each patient and stuff, with their parents, a whole MDT around them. And then whenever I wasn't in meetings, I would be doing my jobs. So my jobs and responsibilities were mostly from the physical health side. If there was any type of like emergencies, seizures or self-hurt, or just regular things as well, like if somebody's hurt themselves as well, maybe they've punched a wall or something, then I need to review and then see whether they need to go to the general hospital, whether they can stay here, whether they need an ambulance or not. Because of course, even though it is a hospital, we don't have access to the same general health facilities as a whole physical health hospital would. I would also do documentation, so letters and things, and then I would also speak to or refer to other doctors. So for example, if somebody had epilepsy and we needed like advice, then maybe I'll speak to their neurologist. I'll speak to gastro sometimes, or Jerry's, and then we'd also have a GP that came in weekly as well. And that's because in mental health, physical health can really suffer, so we make sure that we're very proactive about physical health. In the general population, it's 2% of children and 2% of adults that have learning disabilities. So of course I've been exposed to adults with learning disabilities before, and because they often have worse health outcomes, then they are more likely to be in hospitals. However, being in a specialist job, it's just gonna allow me to modify how I treat my patients with LD, because I feel like now I'll be able to understand them better. So I'm really thankful for this job, and I'll be able to understand them in terms of their physical health needs, and then also their emotional health needs and their mental health needs. So in terms of what I've learned and what I'll talk about in today's video, split into some common themes. So one is trauma, one is challenging behavior, teamwork, and then the NHS in general. As a society, we definitely infantilize adults with learning disabilities. This probably does come from a place of care, because it's of course they need extra protections and things, and also the way that we might categorize them is working age of 2 years old, or working age of, and then say where their milestones stop developing. However, I would want to just push back on this, because the thing that separates children from adults is not necessarily intelligence, because there are some children that are more intelligent than adults and vice versa, but it's probably like experience. That could be negative and positive experience. A lot of my patients had gone through a lot of trauma because one, just as adults, you go through things. And number two, they are much more vulnerable to the things that we all go through. So things like SA, parental emotional abuse, grooming into gangs. Yeah, and then having to be moved from pillar to post because of different care teams and different providers and things like this. So they've gone through a lot of trauma, that these are, the most vulnerable people of our society. They may not always have the concept of time, but like one of my patients around wintertime, they find that difficult because that is when, this was like 2 years ago, that was when they were admitted to hospital, and that's when they had their placement breakdown. So it's like literally the body keeps score and knows that, oh, around this time is difficult for me, but maybe they might not be able to articulate that. So then this moves on to the challenging behavior, because of course if they've gone through all of those things, then the way that they may communicate their difficulties much more, because I think that now the difference between adults of the majority population and adults perhaps with learning disabilities is that us adults, we've just learned ways of hiding our true emotions, but with them, they're going to show their true emotions. So some of the challenging behaviors we might see is self-hurt, and then also like meltdowns, so kicking out, punching out, and that's all coming from a place of anxiety, screaming and things like this. And so how do we manage that challenging behavior? So in learning disabilities, it's all about getting to know the patient first. The psychologists work closely with the patient in order to make an arousal curve. So it's kind of like we are going to be preempting what would make them dysregulated in the first place so that it doesn't happen. So for example, if we know that after a busy day that person then tends to have a meltdown, we make sure to put them in the chill out room so that they can have they can just deload before then going back into the busy ward environment, and that avoids a whole episode. And now, but if it's too late and then somebody is heightened, verbal de-escalation or redirection, or just letting them know that like Jessica's safe now, type thing like that. So one thing that I learned from the clinical psychology consultant was that every behavior is trying to communicate a need, and a lot of the times the challenging behavior could be communicating anxiety. So something like, you're safe now, or we're doing this now and then next we'll do that. Just like very plain, clear language where you're taking charge of the situation for them to know that like you are able to look after them and that they're cared for. If then now there's too much violence or all those things have not worked, then the nursing staff are trained in something called PMVA, which is different holds and stuff in order to keep the person safe. And then now, last line would be PRN medication. So if they're really anxious, really heightened, then might need a bit of lorazepam. And only one instance did we need to use IM for one patient where they were self-hurting themselves too much, and it was to a point where now their physical health was at stake. So I had to prescribe IM medication. That was very traumatic, and I just really think, and actually had a nightmare after that because of everything that was going on. And that is where like teamwork comes in, because then the clinical psychologists that were part of the team like did a debrief of the whole team, because it was very traumatic for everybody involved, and then also came to me specifically and asked me whether I was okay and things with everything that had gone on. We never want to use IM medication, so like injections, on our patients, but it's something that we do have to use in psychiatry sometimes as a last resort. The first time I've had to prescribe IM for somebody with learning disabilities, so it felt an extra layer of I can't even describe it. I guess the feeling is guilt, even though it was for their own safety. Yeah, we're able to debrief, and I'm really glad that the psychologist came to talk to me directly, because sometimes as doctors we're not so much on the floor all the time with the patient. So when traumatic things like this occur, sometimes we can think, oh, just get on with it, because it's the nursing assistants who get the brunt of the aggression and the physical assault and things like this. So it was nice that a psychologist did include me in that debrief, in that conversation. Yes, as I said, the teamwork and on the whole MDT, so it was psychologists, it was us as the doctors and psychiatrists, it was the nursing assistants, the mental health nurses, social care workers, like one thing that I love about the NHS is the teams that you work in, and in LD, it's like medication is just a starting point. It's really the team around that is gonna help that person live their best life. And I really did see that, people going above and beyond. Yeah, shout out to social care workers, because they're the ones that like really look after adults with LD in the community and things, and they have to coordinate so much. Shout out to the whole team. Shout out to people who work with the most vulnerable people of society, because underpaid, overworked, compassion stretched to the limits. But yeah, they came like day in, day out, and it's definitely gonna like inspire it's definitely just taught me so much, this job, basically. So yes, all in all, I really enjoyed this job. Everything that I learned, I feel like it's gonna make me a more compassionate and like switched on doctor, and I now know more about human behavior because I've been able to see it in people who don't have the faculties to hide their behaviors. So I get to see like kind of human behavior in its rawest form, which has taught me a lot. And I guess the main takeaway that I will always remember is that every behavior is trying to communicate a need. And I guess I'll try to like apply that in my own personal life when I'm dealing with difficult people. Or when I'm arguing with my loved ones, I'll try to apply that, but I'm not a saint. And yes, so I hope you liked this video, bit of a chit chat. So like if you like this video, comment down below if you have any questions, or if you have any experience working with people with LD and you have any comments or extra learning points. And I'll see you in the next one. Bye.